speaker, Brian Hoppala. Brian is passionate about finding solutions to improve healthcare despite increasingly limited resources. Originally from the Upper Peninsula of Michigan, he naturally focuses on practical approaches to the industry's problems. Brian has 17 years' experience with Stroudwater Associates, a national firm that is recognized for its leadership and advisory services to hospitals and health systems. His expertise is focused on both affiliation planning and facility strategies and financing. Brian holds a master's degree in health services administration from the University of Michigan and is recognized as a fellow by the American College of Healthcare Executives. He has worked in every region of the country, from Alaska and Hawaii to Maine, where he resides. Brian, I'm turning it over to you.
Great, thank you so much. Happy Friday, everybody. I appreciate your time on Friday afternoon in New England. It is beautiful, so we will work through part 2 of this important topic and then hopefully get out and enjoy our afternoons. Now, part 1 included a lot of information about things that were happening in the industry and how rural was trying to make its way in those changes. And for some of you on the call, it might have looked and felt a little bit like this picture here. This is actually the start of a triathlon when you see the ribbon there across. Everybody's waiting eagerly behind this ribbon, but it's very chaotic. Everybody's really close together, and next thing you know, the gun is off and it's time for everybody to start swimming, and everybody's going in the same direction, and it just feels chaotic. So hopefully by the end of today's session, we'll have cleared the water a bit, and we'll have some clear swimming ahead as it relates to what we really do about these changes in the industry and how that helps us create a sense of direction within our affiliation strategy. When we looked at the agenda for today, we thought that the first thing that we'd want to do is do a brief review, 5 minutes or less, and then really focus on how to move forward. For those of you not on the call last week, we, Stroudwater, have a number of folks that are dedicated to providing advisory services to rural hospitals across the country. And today's presentation really draws on a lot of those experiences and incorporates over really 17 years of experience of working with rural hospitals and in many cases helping them through these partnership questions. Last week we kind of finished with what Stroudwater calls the shaky bridge in really painting the picture of how we as an industry are transitioning from fee-for-service payments to population-based payments. And we in rural in particular have to be mindful that as we make this transition with those limited resources Kim mentioned in my introduction, that we don't fall off the bridge, that we're able to successfully navigate the volume-oriented fee-for-service world and really begin to realize our success and potential under the population-based world. You'll remember that when we talked about last week the 3 elements, or at least 3 of the principal elements around how rural creates value, it fell into these categories generally. The first is how rural providers are already providing efficient care and high quality care, and making that transition to increasing our levels of efficiency and increasing our quality is something we know many rural providers are hard at work on. So this is an area where we are already doing well overall in rural, and know that there's more work to be done, but many organizations are using lean and other tools to really provide an efficient service to the community. We know the second element we discussed last week is that our alignment with primary care physicians in rural is a really strong point about making this transition from fee-for-service to population payments. And much of that relates to the concept of attribution within a population for where primary care gets delivered, and that at that point of attribution is where we can really start to influence changes in care, better coordination of care, better management of chronic diseases, etc. And then eventually, as we transition our payment system to support that, really start to take advantage of those historical contributions that we've made in primary care practices. And take advantage of them, I mean by saying monetize them, to be able to substitute some of the losses that we'd be experiencing with lower utilization, and be able to realize some of the gains downstream, the downstream dollars that we're saving because we're managing resources effectively. That, of course, goes right into the third bucket, which is really being able to be part of a broader delivery system that makes sure that folks are in the right bed at the right time or using the right outpatient service at the right time. And being able to look across the population and most effectively manage the per capita costs. And you may recall, if you were on last week's call, that in rural, our standard practice is to provide on a population basis lower cost care per person than our urban counterparts do. And we talked about some of the reasons that is the case, particularly as it relates to judicious use of resources and really having, I think, a good comprehensive and holistic understanding of our patients in rural. In rural, physicians, the ones I talk to, really do understand what patient-centered medical home kind of care is like because they've been doing it for so long. So these are really the areas where rural can contribute significantly to the health system of the future. Efficient care, primary care-based, and really understanding total utilization of resources. Now, as we move into this new world, this question around partnerships and affiliations really carries an important question. The question is, what kind of risk are you as a rural hospital able to best sleep with at night, if we think of it that way? Notice the common denominator here is risk. On one hand, we have risk of execution, and if we are completely on our own, then and we're navigating these changes and making these transitions, then the risk that we're faced is really our own ability to have the resources, to have the expertise, to have, frankly, the time to be able to make these changes, to see them through, and to do it all on our own. So there is a risk with the independent strategy, and that is, can we really create the effects that we need to in the time that we need to in order to respond to these changes in the industry? On the other hand, the idea of how we think about partnerships and affiliations is also laden with risk. We should not go into these arrangements thinking that they are somehow the panacea or solution. Remember, we think of affiliations not as the goal, but as a strategy to help you achieve your strategic objectives. So partner risk and really understanding how what we can depend on our partner to do and how they really see their role playing is much of what we'll be talking about today. Understanding that we have a number of different balls in the air, so to speak. We have the organizational needs and constraints, the things that we may want to get out of an affiliation, the things like access to enough scale to support a population-based payment. Last week we talked about ACOs. It's not the only model, but as we think about being able to aggregate payment on a population basis, one of the concerns, obviously, in rural is we have small populations, and in one or two cases could really blow our budget, so to speak. So that's a need for scale, so to speak, that is a constraint given this change in the industry. We have strategic objectives, and we certainly have other objectives that are not related specifically to payment. We have objectives related to being able to recruit and retain staff, recruit and retain physicians, and those are important objectives to understand. And as we focused on last week, we also have something to offer the healthcare delivery system, large systems, tertiary care centers, and others. And all of those things really, from a process standpoint, all of those things accumulate into considering a set of options as it relates to affiliation and partnership. And I want to emphasize here that we're talking about options. And one of the common things I hear as I start to talk to boards about affiliation is the knee-jerk reaction. And I get it. I'm from a rural community, and I understand, you know, as soon as we start to talk about partnership or affiliation, we automatically think about, well, we're selling out, or somebody else is going to come take this away from us. And I just want to back us up and say, as we go through a process and as we start to introduce the idea of affiliations or try on different options, we have to remind ourselves that at any juncture we can stop and say, this doesn't feel right, we're not going to move forward, we are going to take a different strategy. This is, you as hospitals, and certainly from a board perspective, are very much in control of this process. And when we remind ourselves over and over again that what we're doing is optional and that we're just looking at these different scenarios to try them on, it's really key to overcoming some of that initial concern and resistance. Now, there's this saying, I'm not sure who it's attributed to, but I know a mentor of mine early on in my career used to say this to me regularly, and she'd say, facts are stubborn things. And sometimes as we're in organizations and even at the board level, it's hard to see the forest for the trees. And so one of the best ways that we can do that is to really evaluate some cold hard data and put that relative to some benchmarks or parameters. And so what you see on this slide really, it's an organization, this is their actual data, it's a case study. And what it shows is their cash flow, which is in this case approximated by their earnings before interest, depreciation, and amortization, so it's EBITDA. And those are the bars there. And so that's the amount of money, very successful critical access hospital. That's the amount of money that they are throwing off on an annual basis in cash. You can see the bars there as they go along from 2012 and 13, very good and increasing performance, and then 14, 15, and their 16 budget kind of has come back down. Again, good, strong cash flow, but it's come back down. The lines that you see across there really reflect what we would consider to be some different thresholds of performance. The first threshold of performance is survival, and that really means that we're meeting our long-term obligations to the bondholders or banks if we have any kind of long-term debt. So that first line you see there is, the red one is survival. The next one up is sustainability, and we define that as meeting our obligations through debt service, plus being able to reinvest in the facility. And we use facility and equipment. We use 120% of annual depreciation as a way to approximate a good, healthy level of annual investment. Certainly organizations can get away with a little less than that, but over time, that starts to catch up to you. The third threshold there, the blue line, really is what we call thriving, and that includes an additional margin of performance on top of that. So coming back to this, when we are thinking about affiliation and when we're thinking about our ability to execute on our strategies by ourselves, we need to really understand what resources we're going to have available. And this is one way to look at that. As I made the offer last week with some other models and tools that we have, if anybody on the phone would be interested in having their performance looked at through this lens, I can certainly provide the resources to do that following this call. Bottom line here, facts are stubborn things. This is an organization that's performed very well, has very good financial performance overall, but has declined relative to some of the thresholds and benchmarks that we'd want to be able to see on a going forward basis. So it begs this question, when do we decide to start these conversations? And I would say historically, many cases motivated by our fear of the loss of control. Rural hospitals have waited to the very last minute. They have exhausted all other possibilities, and they're now thinking, okay, who can I have as a partner to come in and save me? On this chart, you can kind of see our thresholds here, and then you see this line, and what it shows is that as financial performance decreases, so do the number of options. So if we wait until we have 3 days of cash on hand and we've run up our payables and we've kind of exhausted all other possibilities, and we now have to, quote unquote, find a partner, what we're really getting is somebody to come in and take us over because we've got no other option. What we encourage, and certainly would encourage the folks on the call to think about, is understanding and looking at your affiliation options as your financial performance is strong really does create a whole new realm of possibilities. There's no sense of urgency, and certainly if you get to the point of where you're having specific discussions around the aspects, the specifics of a negotiation, you have a lot more leverage because you've got that financial capacity to offer and to fall back on if you decide to walk away. So understanding the relationship of this and really being able to help boards understand this indicates that it's not healthy to wait too long, and while there might not be what we would call a burning platform if we're doing this early, it's a good opportunity to create some conversation around what the different options are. So as we think about the goal specifically, we at Stroudwater use the term interdependence. And if you're any kind of Stephen Covey fan, you'll recognize immediately that we totally stole this term from him. Interdependence is the stage that you might remember is kind of after dependence, and we move from dependent states to independent states, and we really kind of establish our own identity. And then Covey would say, and we see this analogy happening in the healthcare industry, that in order to really continue to evolve, we need to be interdependent. It's built on the strength of our own independence, but it also recognizes that we are intricately connected to what happens in other parts of our, in the case of Covey lives, or in the case of our delivery systems, what happens in other parts of the delivery system. So readmissions is a great example of this in the sense that we can provide great hospital-based care, but if people do not have effective access to post-acute care, home care, family support, additional primary care, the linkage is not made back with primary care, all of these different aspects, we know practically increase the probability that that person would end up back in the hospital for the same medical condition and be counted as a readmission. So we know that the delivery of care is already interdependent. And what we're saying around the overall affiliation strategy is that we want to accept that and start to build on it with a common goal and to define some common expected results. There are some listed here. How do we understand the measurable improvement that we can get from a readmission perspective? How do we understand in terms of the protocols, not just in terms of the people that are sitting at the CEO's table and making these agreements, but how do we create tighter connections among the folks that are actually practicing care so that when an emergency room patient needs a transfer, that happens very seamlessly, and that when that person is really, from an acuity level, appropriately transferred back to the rural community, that also happens seamlessly. And I think a great example of this in the industry is really the work that the Mayo Clinic has started to do. Of course, we all know the Mayo Clinic as it relates to its preeminence in tertiary care, in managing the cost of care and its alignment with physicians. And really over the last number of years, it's really established preeminence around its ability and understanding of how to work this system of care with rural hospitals. And I'd encourage anybody on the call to look into the models that they've created and to communicate those with their boards and with their potential partners, because it really is a fabulous set of models. I've been using a variety of different ways to talk about potential partners, in part because there are a lot of different kinds of potential partners. The ones listed here are the ones that we see most frequently within rural hospitals. The first is that we have, in many cases, historical network participation or alliances where we are working with like-minded hospitals, like-sized hospitals, and understanding that there is more that we can do together. I know that the Rural Health Resource Center and Terry's organizations have done a tremendous amount of work nationally in working with networks and really helping them improve their effectiveness and helping them really improve the services that they're able to provide to rural hospitals. It's amazing to me to find out that folks are not always participating. Leaders do not always participate extensively in the networks and alliances that are available to them. There are new networks and alliances that are being created. I know the Illinois Critical Access Hospital Network is looking at developing what they're calling a CCO, Coordinated Care Organization, really across multiple rural hospitals, and really starting to create enough scale across those entities to begin conversations around this transition to population health. And it's a fascinating project, and those are just a couple examples, but the things that are going on out there in the field. There are multi-hospital, not-for-profit systems that are increasingly, frankly, interested in rural hospital partnerships and affiliations. One of the things I would say is that it's refreshing to see a lot of systems that are starting to understand that their historical approach to their systemness, the network development, that it's not going to work for the future. That being primarily characterized by kind of a hub and smoke or a hub and spoke or a command and control kind of environment. So we do see systems that are strategically becoming much more collaborative and much more interested in rural hospitals, whereas in the past they hadn't been, generically speaking. I know there are exceptions. We're also seeing not-for-profit systems that are looking to expand their geographic market or enter new markets, frankly. And so there's a wide variety of different arrangements there. And I would say that one of the important things around the process, and And having gone through this with many, many rural hospitals, we typically would interview, for example, at the beginning of a project, the executive leadership team, the board, the physicians, some other key stakeholders, and really start to understand what their perceptions of not-for-profit the systems are that are serving their community. Sometimes geographically, people may split and go to different communities. Sometimes they may go to one urban area, but there may be multiple systems serving that area. So it's really interesting to get some of those issues out on the table and then really come back and depend that back on our facts being stubborn things and start to look at, for example, what the system performance is relative to quality scores or pay for performance, what the system's strategies are relative to population health, to doing shared savings programs, et cetera. And in many cases, there's a perception that certain systems are ahead of others, and when you look at the data, it doesn't really bear out to be the case. So understanding that at the front end and then getting some data to support that is really important. There are also for-profit health systems that are out there, particularly targeting rural. There are some private companies and there are some publicly traded companies that have targeted rural and understand that when they are looking in these communities and in rural communities for partnerships, for the most part, these organizations are looking for complete asset acquisitions. And as a county hospital or as a not-for-profit hospital, if this is of interest, there is a very specific process of determining fair market value in many, many legal considerations relative to this. As assets in the public's interest and trust get transferred, there needs to be recognition of that. But there are these partners out there, and in many cases, depending on your market, there may be some of these individuals that are interested in your rural hospital. Other options, joint ventures, equity, are available to some larger hospitals. I've been doing rural long enough to recognize that there is a lot of diversity even within the critical access hospital programs. So if you are a larger critical access hospital, it's important to know that this is not an exhaustive list for your kind of organization. So one of the most important things that we see as an action step is to really understand what the strategic opportunities are and what the drivers would be for your organization. I've gone through generically what some of the issues are in the industry, but clearly markets are different. If you're in a market where Medicaid is moving aggressively or is already in a population health-oriented system, that's very different. If you're in a market that all of your payers are still paying you a high percentage of your charges, that's very different. So there's a lot of different considerations here, but really there is, in every organization that we've seen and done interviews, there is a list of things that could be of help or benefit to the rural facility. And it's important to think those through in a way where we engage the perspectives of multiple entities and understand that, again, we're just thinking about options, that we're trying to create a tool to be able to communicate what this could potentially look like, what the potential benefits of it would be like, and if we ever took it to the place where we went out and started to solicit different opinions or offers, that we would be able to use those same criteria, the same way that we expect to benefit, we could use those in a way that would guide decision making. So it really provides us an internal way to think about what the opportunity is, and then it provides us a framework to evaluate different ideas that we might get from potential partners. As we think about the process and the board being involved with this, we certainly want to understand how the board can evaluate options on an apples-to-apples basis. Fair evaluation is really key, and to offer that level of consistency through the process. So just as a point of example, an affiliation process may take anywhere between 6 and 9 months depending on how extensive the affiliation is. And frankly, sometimes when you get in the middle of it, it's really helpful to come back and take a look at the affiliation criteria and remind ourselves and all of our stakeholders why we're doing this. What do we want to accomplish? And I'll also say, not knowing if there are any of my attorney friends on the call, but attorneys will certainly be involved, and as good attorneys do, they want to make sure that they're representing the agreement in the most accurate way, and that it gets to be very specific, and that these affiliation criteria really help demonstrate and document what the attorneys would need to have in order to create the agreement, whether that's a very simple contract or something that's much more extensive, such as an asset purchase agreement or some other form of a legal agreement. We came up, Eric Schell, my colleague, and I were sitting in a rural hospital in Mississippi, must have been 12, 14 years ago now, and we were asking some basic questions around why the hospital was in affiliation with its tertiary care partner, and recognized that there wasn't really a systematic way to think about that. So literally on the conference room whiteboard, we created this idea and concept around thinking of affiliation not as everything being created equal, but thinking of it as there being some activities on the operational side, so kind of the left side of this, thinking of some activities in some resources that are much more operationally focused and that are valuable, but those being different than some other kinds of activities on the right side of this spectrum where those are much more strategic and where there's actually, if you're effective, a lot more value associated with that. So this affiliation value curve is broken into two sides. On the top are the expected benefits that rural hospitals would look for, starting on the left-hand side here with improved image. Some affiliations simply are kind of on paper, we're working together, generally speaking, and there's an announcement made in the paper, and we talk about being an affiliate of the larger hospital. And in some cases, that can provide like a halo effect for the rural hospital in the perception of the community. Not really, practically speaking, anything is changing as it relates to quality of care, but rural folks might be, some of the residents might be more willing to give it a try because of this halo effect. Next along is being able to jointly purchase services, often on the system hospital's GPO contract, or be able to get services directly from them at a much lower rate, kind of on marginal cost as opposed to buying everything from third-party vendors. Certainly offers some cost savings value to rural hospitals. Being able to coordinate services is the next idea, and often the example there is being able to put in place an example with swing beds. Understanding the rules around the transfer provision that tertiary care hospitals face, and understanding the swing bed role in providing skilled level care on the back end of orthopedic procedures and other kinds of things, and being able to put a program in place where that is of benefit. Management support, that takes a lot of different varieties, including some cases employing the CEO, and some cases employing the entire senior management team, up and through into including really providing consulting services from managers to managers so that lab folks have an expert within a system that they can call on, and again, doing that at more of an incremental cost basis. We define this thing we call the commitment gap because there's a lot of things that we can do on the left-hand side of this curve without really, quote-unquote, getting married, but you'll see when we start talking about investing capital and we start talking about jointly or having a system do a guarantee or providing capital directly, obviously that connotes a different kind of relationship, much more committed relationship depending on the amount of capital, but certainly much more important. Technology integration. Boy, a dozen years ago, this was a little bit of a dream, but we are really now starting to see a lot more joint electronic health record work, and many systems are really starting to lead with this as a strategy. Now, it's over on this side of the curve because it's a very strategic decision, of course. When we start tying our EMR to a particular system, but it is providing access to health record technologies that, frankly, rural hospitals could never possibly afford on their own. Physician integration is the next category up the curve. Certainly a lot of work here as it relates to the recruitment retention mentioned earlier. And really, I was just working with the hospital last week, and this one strikes at physician integration because the primary care physicians in this community were talking about one of their potential system partners and saying, it just doesn't feel like there are any exit doors from the system. So if I send a patient there, the patient just stays in the system and I never get them back. And that's a concern I've heard from rural physicians in many, many different places. So it really does have a lot to do with the system and how they're thinking about really honoring that role of primary care and making sure that the coordination of care goes back. And then ultimately clinical integration, which again a dozen years ago was kind of a long ways out, and here we are now where we're really working, driven in some cases by the different market incentives, but we're really working in a different world where this idea of how we coordinate across the continuum of care and clinically integrate is really important. Certainly systems are starting what they're calling CINs, clinically integrated networks. Rural hospitals in some cases are participating in those, so we're seeing a lot more activity there as well. So to back up for a moment, the top side of this, which I've focused on, is how rural hospitals would get value. I'm not going to go through the bottom side, but really what we've appreciated, might have been a year or two after we did the first draft of this, but we started to understand that if this was going to work, and I say this, if effective affiliations were going to work, we needed to know how our system partners were going to get value at each of these different nodes. So we can't expect for folks to be happy over the long term if we're getting value somewhere over here on the right and our system partner is getting value somewhere over on the left. That's not an effective partnership. So we talk a lot about alignment and about making sure that we meet with and discuss and really understand what our system partner wants to be able to get and what we want to be able to get, and working on the alignment between those two. This is an example of that mentioned earlier around joint capital investment, and we are certainly seeing a lot of work. I do a lot of facility planning, budgeting, and feasibility studies, and understanding that from a system perspective, when we're looking at a rural facility and we're thinking about the ambulatory program and how it fits in with the system resources, these are really important questions. So rural hospitals can get access to credit and improve cash flow, and the system's really looking to be able to diversify system assets. And for those of you who have read through the slides, there's some more specifics as it relates to how this kind of works, whether that's delivered through guarantees or whether we're using any kind of federal programs, mortgage guarantees, USDA, et cetera. Lots of different ways to solve these issues, but some examples here. So in terms of an overarching process, when we often get a question from a CEO saying, okay, you've convinced me that I need to do something, but how do I do it? What does this process look like? Really three important aspects that you see listed as it relates to success factors. The first is, as I just mentioned, how do we work towards alignment of goals? The second is the selection approach. By the selection approach, and you kind of see that listed on the right-hand side of this slide, it is really important, we think, to take a step back from what might feel like it is the natural decision as it relates to who a partner might be or what your approach might be, and really evaluate the strategic needs and develop the affiliation criteria that I mentioned before, and then use those to solicit feedback. And we call it an RFP, a partner RFP. We know individual hospitals do this effectively. Groups of hospitals sometimes do this. So 2 or 3 hospitals might come together and do the process jointly. Really what this is doing is it is allowing potential systems to, in some cases, surprise you with how they're interested, what they might be able to do for you, etc. And it's important to take that fresh perspective, because going out and talking to the market, in this case talking to potential partners, sharing your goals and aspirations, sharing your affiliation criteria, it allows you to have a conversation that's specific and tailored to your needs, and it allows you to really understand what the potential is, not predetermine or pre-assume what that potential might look like. The selection process itself, mentioning earlier, should use those affiliation criteria as the decision-making framework. Often would include having potential system partners or potential partners doing presentations with you and your board to really understand who they are, be able to look at issues that would be important to you, like culture, and be able to do that in a way that is systematic, so that everybody's hearing the same thing, so that we all are working off the same information and the same page and understanding. Understanding that we need to do some due diligence, and just because an organization is big and has a lot of zeros in their balance sheet doesn't necessarily mean they're stable, or that they might be looking for their own partner. So doing due diligence and working under an MOU, or a Memorandum of Understanding, really important. The Memorandum of Understanding really specifies how you might be working together, and then due diligence is really the process for determining, going back to partner risk, determining and really getting a good feel for your partner's ability to execute on their part of the agreement. So if we're doing a basic agreement around some shared services, the due diligence would be around what their experience has been. We might talk to some of the hospitals that they're providing the shared service to already, etc. If we're talking about a more extensive agreement, we're talking about a complete asset purchase, then there's much more extensive due diligence that would be done on both sides. So this is an important aspect, but it really is the homework to make sure that we're starting to manage that partner risk that we talked about earlier. And then we'll have some agreement, definitive agreement, again, varying in complexity relative to what the needs and structure of your proposed partnership is. And then the last one is communication. And the communication here really comes back to not being apologetic. frankly. Again, if we didn't wait too long, if we're not banging our tin cup at the corner trying to find a partner to come in and save us, then we should be able to be telling this story proactively to the community and tell it positively so that we communicate that we are in control of our destiny, that we're really working on this in a way that is in the best interest of the community, that we're not being reactive. Changes are happening in the marketplace, and we're looking to see how we can evolve along with it and what the scale or potential of a partner or set of partners would do to help us along. We definitely want to communicate the reasons over and over and over and over again. Often CEOs will do regular employee forums and really keep people up to speed about what the reasons are and come back to those affiliation criteria. The board chair and in many cases the chief of staff are often very involved with these forums and with the press and the public, communicating what process you might be using and what options you might be looking at when it comes time to think about those. Really looking to create a consensus, and when we do this early, we always know that there are the folks that will respond from a knee-jerk perspective, but if we don't reach out to them and really engage them in the process, we find that whatever you're going to try to do downstream will be hampered, because those folks will come back tenfold and they'll have spoken with folks. So in some cases, for example, we might do a physician advisory component to really make sure the medical staff and the primary care physicians in particular, they have a real seat at the table relative to how these conversations evolve. Rumors will come up. Again, the last time I was doing interviews, as the interviews were happening, people later in the day were coming in and telling about the rumors that were already circulating, about the guys that were in the boardroom that were here to sell the hospital. So, we need to deal with this stuff quickly and directly. Certainly, honesty is the best policy here, but in many cases, the status of where things exactly stand might be bound by a confidentiality agreement as you're working through details. So we just need to be upfront with what we can share and what we can't share, but be able to effectively communicate and deal with any kind of rumors. And it goes without saying that folks, when we think about this, for good reason, think about how this is going to affect them, whether they're going to have a job. It reminds me of back when I was working on an ambulance and was training to be an EMT specialist and work out in the field, and my trainer said the worst thing that you can tell somebody is that it's going to be okay. You might want to do that, you might want to provide them that comfort, but that's not your role. Your role is to help them, to work with them, to in this case provide life support, but don't say that. And so in this same framework, many affiliations do not affect jobs and don't. People don't lose their job. If there is a full affiliation or some other kind of structure, just don't overpromise that. Don't try to tell people it's going to be okay and then then change it at the last minute. I think, again, we want to talk about the reasons and help people understand specifically what's going to be put in place. Many affiliation agreements will have specific provisions that protect folks, the benefits, et cetera. So if that's important and important to your people, and it mostly is, then we need to make sure that it gets included in the process and in the actual affiliation agreement itself. So in terms of success factors, be open. There should be no agenda, preconceived outcome. Continue to work on your knowledge of affiliations, work with others who can bring examples to the table, understand that there are many, many different ways to solve a problem, and having seen a number of them can help you customize what works best for you. In many cases, it does help to get outside advice. Certainly, you will need to have attorneys involved, again, depending on the kind of agreement. That may be very brief and it may be extensive. Attorneys that are particularly expert on healthcare issues and healthcare affiliations are increasingly important as the affiliation moves towards the right side of that value curve. As the commitment gets higher and the legal structures get more important, we have to put a premium on attorneys and other professionals that really understand the process. Certainly consulting can be valuable. In many cases, quarterbacking the process itself, recognizing every rural hospital CEO and leadership team I've met is busy and then some just running their hospital. So it can be helpful to get outside assistance in terms of running a process and making sure everybody has the communication that they need to be happy. Facilitating those discussions with boards, physicians, doing retreats, doing planning sessions. I mean, these are all things that are very important, and being able to successfully facilitate these and not let the emotion take over is pretty important to the process. Once we get to any kind of negotiation, even simple contracts get negotiated. There's a skill set that you want to have there, and being able to manage the process, as I just mentioned before. So in conclusion, and Kim, I think we will have time for a couple questions, but
absolutely,
your path forward in some practicality here is, number one, get going on some education, and from a internal perspective with leaders in the organization, with board members, et cetera, looking at affiliation trends, going back to the toolbox that we talked about last week, and again, any questions on those tools for demonstrating rural value, please get in touch with me. Doing some of the risk assessment, really looking at the fact base that I mentioned, the financial status, the operating and partnership risks, talking to folks and using the affiliation criteria, and then we use these things called must-haves and cannot give-ups. They simply are things that we can put into categories so that we can document them from stakeholders as it relates to the things that, as a must-have, we would certainly want to be able to benefit from a partner. The reasons that we would start it, and the cannot give ups are the things that we already have that we would want a partner to change. And then communication, being proactive and positive, which I just finished with, and will certainly not beat that dead horse. So thank you for your time, and Kim, I'll turn it over to you for questions.
Great, thank you so much, Brian. If anyone has a question, you may unmute your line by pressing *2, or you may type it into the chat box. Brian, here's a question. What advice would you give to a CEO who has a board that believes that Obamacare will be overturned in the next election, and they just continue to go it alone in the future?
Yeah, I hear that a lot. We do a lot of work in the South and in other, what you might call, red states. So the thing that I would say relative to the changes that are happening at the federal level as it relates to Obamacare are, in many ways, only part of the drivers. And I think last week's webinar went into some of the other ones, but for example, employers are becoming much more active in either directly sending care to places that they perceive to be high value or low cost, and if they're not directly involved, then they're pressuring the insurance companies to really be creating narrow networks of places of care that are high value and low cost. Consumers are much more discerning themselves relative to the out-of-pocket costs that they may face. So the federal changes are certainly part of it. if accountable care organizations went away tomorrow, I would still say that the idea of how we work across the system, how we can be more efficient and provide higher quality, these are still issues that are going to live on, again, because the employer market's driving it, the consumer market's driving it, and if the federal government doesn't drive it for a while because somebody repeals Obamacare and they have to go back to ground zero, or they have to go back to a fresh piece of paper as it relates to how to solve the Medicare issue, it's not going to take the other drivers away.
Great, thank you so much, Brian. Michael has a question. What is being seen regarding rurals exploring alternative care delivery or niche models, freestanding ER plus observation facilities, birthing centers, urgent cares, etc.?
Yeah, I think it's a great question. Really, the bottom line, I would say, is that having a freestanding center is difficult in the feasibility because there's not a payment system that really works well in that setting. There are a couple demonstration projects that are going on in frontier areas and other places to start to perhaps address this over the long term, but the resources that are available, that we need to have available to provide emergency services, unless we have a sufficient, very suburban or metro population, it's really difficult to generate sufficient volumes in and of themselves to support all the other ancillary and support services that we need to have. So we haven't seen a lot of feasibility studies yet that have shown that these models really do pencil out. What we are seeing, and certainly want to acknowledge, is that there are systems that are really out promoting this idea and trying to get and think about rural differently and suggesting that this might be one of those things. And I think these are important conversations to welcome because rural does need, as does the rest of this healthcare system, but we need to transition and reinvent around ambulatory care and primary care setting. And we just need to figure out a way to do that that keeps everything whole. And so I would say it's not as easy as freestanding urgent care, ER, et cetera, but they are important conversations to have, and in many cases, important conversations to have with potential system partners.
Great. Michael, did that answer your question? Are there any other questions for Brian today? *2 to unmute your line, or you can type it in the chat box. Brian, I want to thank you for a great webinar series these past few weeks. The recordings of these webinars are available on our Help Webinar Playbacks page. At this time, I ask that you complete the short online assessment. If you would like to receive a 1 hour of pre-approved ACHE qualified education credit, you must complete the assessment. We have some exciting webinars and calls scheduled for this summer. To register for any of our upcoming webinars or PMG calls, please follow the link to our registration pages. If you have any questions or comments, please contact me at the email link on the screen, and I hope to have you on future calls. Thank you, everyone. Have a great weekend.